Uh, I'm from Addis Ababa University, School of Public Health, Department of Health Systems and Policy, with main focus area in health economics. I have been leading the health economics unit for the past 6 years. So today I will be moderating the presentation on the economic burden of so I will be moderating the presentation on economic burden of blindness and visual impairment. So the presenters are Dr.Ylemayehu Sisay and Dr.Yihalem. So before we proceed to the presentation, I would like to introduce the presenters, Dr.Ylemayehu Sisay. So let me introduce the presenter. So Dr. Ylemayehu is currently the country director of Orbis International in Ethiopia. He is a senior ophthalmologist and one of the leading trachoma experts globally. He has been a strong proponent of comprehensive eye care to alleviate major causes of avoidable visual impairment, blindness in developing countries. His work spans from community level engagement to prevent and treat trachoma, to the establishment of tertiary institutions to address pediatric ophthalmology and other eye care specialties. So he has been passionate about trachoma elimination as public health problem. So Dr. Ylemayehu has led one of the largest trachoma elimination operations in Ethiopia and globally, which has touched the lives of over 11 million people annually. So he has provided technical as well as managerial support to this program. He is also a principal investigator in groundbreaking research related to TT surgery, including Head Start and MTSS. So he has led a successful grant application, program implementation for UK Ed, Irish Ed, Site Saber International, Romania, USAID, Infant, SIF, and other international corporate donors. Overall, Dr. Ylemayehu has over 20 years of experience in clinical and public health practice globally and in Ethiopia as well. And the other presenters we have is Dr.Yihalem Abebe. He is an academic and professional in mainly specialized in health economics. He is teaching and has teaching consulting experiences in health economics researches. So has been consulting from health facilities to universities, Ministry of Health, Ministry of Health and private limited companies. So Dr. Yihalem has conducted an in-depth research in scientific area of health economics. Mainly, he was involved also as a data manager for the National Health Equity Survey in 2023. He was a member of a cost-effectiveness study, a national cost-effectiveness study on soil-transmitted helminth and schistosomiasis infection in Wolaita zone. So Dr. Yihalem was also a lead analyst for the economic return of investment study on adolescent and youth sexual and reproductive health in industrial park workers in Ethiopia. He has also been a co-investigator on the economic burden of malaria in Africa. So in addition to all these qualifications related to the health economics practice, he has also been a co-founder and general manager of Abyssinia Health Economics and Health Financing, Health Technology Assessment Consulting and Training PLC. So he has more than 14 years of experience in health systems. So today I am happy to introduce these two experts. So Dr. Ylemayehu, I will invite Dr. Ylemayehu to start the first part of the presentation. And I would also like to inform the participants that there will be a post-test at the end of the presentation. A link will be dropped. So we'll follow that. So I will welcome Dr. Ylemayehu for the first part of the presentation. Thank you.
Thank you very much, Berhan, for the very kind introduction. Very much appreciated. Dr.Yihalem and I are very grateful to update you on the economic burden of blindness in Ethiopia, and would like to thank the Ethiopian Medical Association and OSE, the Ophthalmological Society of Ethiopia, for inviting us to speak on this subject. To best use of the internet, I'll turn off the video and speak only on the audio part. For a minute, I'm going to upload the slide here. Is that visible to everybody?
Yeah. Apologies, Dr. Ylemayehu, I have shared the slides. Would you like me to stop sharing the slides?
Oh, that would be, thank you, Berhan. Then I'll stop sharing, okay. Is the slide visible now? Sorry. I'll stop sharing.
Okay, is my slide visible, or I have already
I'm
shared
not
the
seeing.
slides?
Okay.
Is it visible now?
Yes. Yes. Can you put it in slide mode, please?
Yes.
Perfect. Thank you, Berhan. Again, thank you, IMA and OSE for inviting us to speak on the subject. I would like to give you the intent of our presentation here. Number one, it's to provide you an update on the burden of vision impairment and blindness and its economic burden on society in Ethiopia. And the second is to foster collaboration amongst the different medical disciplines within IMA and beyond to improve the quality of eye care, and also to bring change and policy influence for inclusive eye health within the existing healthcare system. And the last is to get CME credit for IMA members. Sorry. Can you go to the next slide, please?
Yes. Okay.
Oh, yeah.
Is it visible? I'm sorry, I have some professional here.
It's on the first slide now, yeah.
Yes, I was not able to change the slides. That's why I stopped.
Okay. Next slide.
Hmm.
So in that case, can I share it from my end? You can
Yes,
unshare.
please.
Yeah, you can unshare it, and I can share that. Okay. So I have described the purpose of our presentation, and here is the outline of our presentation. Myself and my colleague Dr. Yihalem will go through each part of this outline. Number one, to provide you the visual impairment and blindness overview of the country, and also economic cost of blindness and visual impairment globally and also in Ethiopia. and also highlight the economic benefit of investing in eye health and the current situation of eye care service in Ethiopia. And the last will be conceptualizing eye health within the universal healthcare system. So as you know, vision is the most dominant of our senses. It plays a very critical role in every aspect of our life. When we say vision, it signifies not only the near and the distance vision, but also other function of vision like color, form, perception, or binocular vision, and the other functions as well. So any aspect of this vision function, if affected, will cause a vision impairment of various degree, and the consequence will be very profound, be it at individual, family, or community level, and of course at large at country level as well. In medicine, the eye is a unique organ in a way that it relates to many different organs and illnesses as well. For a rheumatologist, it's said to be a joint because it shares many structure with joints. With neurologists, it's called an extension of the brain because there are a lot of similarity in the content of the eye and the brain as well. And for a diabetologist, it is a window through which they can see and relate any nephropathy related to diabetic and other systemic illnesses. So its connection and network with many systemic problems is very, very key here. One thing to note here is that quality eye care service globally contribute to the achievement of Sustainable Development Goals. As you all know, there are 17 Sustainable Development Goals that member countries agreed to achieve by 2030. Investing in eye care in a way relates to the contribution of this achievement. So for political leaders, decision makers, and influencers, I think approaching eye care through SDG make absolute sense so that the influence that we require will be achieved. Before diving into the other presentation, I would like to give you some key definitions. What do you mean by vision loss? Or what do you mean by visual impairment or blindness? The World Health Organization categorized vision loss into 5 categories. Blindness, as defined by the WHO, is less than 3 meters per 60. Ethiopia uses a metric system, so whenever I refer to the numbers here, it relates to meters. And severe visual impairment relates to visual acuity ranging between 660 to 360. And moderate visual impairment relates to 618 to 616, and mild visual impairment 612 to 618. And also, as I have described earlier, vision has both distance and near function. And also, as we age, we need to have a reading, assistant or spectacles, and that depends on the measurement for near vision, as described by WHO as well. The other thing to note is that vision loss may be permanent or treatable. There are eye diseases that could be prevented or treated. These two groups are called avoidable blindness, and there are some that cannot be avoided, and these are called permanent blindness. I would like to draw your attention to the Sustainable Development Goals again, because that clearly indicates the impact of investing in eye health to the achievement of SDG and also to relate to other public health issues. For example, number 1, no hunger. Poverty is both, no poverty is number 1 goal. It is both a cause and a consequence of poor eye health. Often, poor people are predisposed to blindness because of lack of information or awareness or economic related issues. And that causes to blindness. And once they are blind, they are also poor. So the vicious cycle of poverty and blindness is very, very critical to note here. And the second is no hunger. Improved eye health can increase household income because it improves productivity, the visual function is good, they can be contributing to many aspects of societal development. So no hunger is very critical. And the other is eye health is a key to ensuring good health, mental health, and also well-being. And we can list all the key SDG components that contribute to eye health. Number 4, number 5, number 8, number 10, and 11. All these, you can see the data described under each goal contribute to the achievement of SDG. What I'm trying to emphasize here is that by investing in eye health, we definitely contribute to the achievement of SDGs. And this is very relevant to those key decision makers that I have described earlier. That being said, based on the most recent data from WHO, which is published also on Lancet, at least 1 billion people have a vision impairment, and 2.2 billion people have one or the other form of visual impairment. And of that, 1 billion people have a vision impairment that could have been prevented or is yet to be addressed. This is a profound burden of vision impairment on society. I'll come later into the inequalities and the other aspects. So what are the major causes of vision impairment? The leading cause is refractive error. And as you can see, it has two components: as a cause to moderate to severe visual impairment and as a cause to blindness. This combined will lead to a significant contribution to the overall burden of vision impairment. So investing in refractive error, which is a simple, cost-effective, efficient way of providing spectacle, is a way to alleviate this burden as well. Cataracts, as the number of people globally are aging and the number increases, the likelihood that we can see a significant proportion of people with cataract will increase as we go along. So cataracts, both as a cause of visual impairment and blindness, is significant. In fact, it is the leading cause of blindness globally. And the other is macular degeneration. As I have said, as we age, like any aging process in our body, our eyes also age, particularly the retina will undergo degeneration, and that's called age-related macular degeneration. Glaucoma, an increase in intraocular pressure with visual field defect and so on. That is a significant cause of vision impairment. Diabetic retinopathy, it's becoming an epidemic, both in the developed and the developing country. And that is becoming an emerging public health concern, particularly in the developing world, as the healthcare system is not able to handle those cases. And all other causes combined are shown here to contribute to that pool. One thing to note here is that infectious causes are not listed here. Probably in the other category, in the other vision loss category, we may have a little proportion of it. I'll come later why I'm saying that. Here is the report from WHO again. As you can see, 1.1 billion to 1.7 billion people will be affected by visual impairment by 2050. If we don't have any public health clinical or public health intervention, you can see the projection by 2050 will be significant. 1.7 billion people will have vision impairment requiring, different services. And the other thing is, as at individual level along our life cycle, at one point or another, the likelihood that we'll have eye problem is very, very clear. Inequality. I mean, this is a very important report from the World Vision Report. I think vision loss is driven by inequalities. That report indicates greater than 90% of the vision impairment is in low and middle income countries like Ethiopia. So that is a massive burden reflected here. And more than 73% are in the age group of above 15 years old. It affects, vision impairment generally affects people above the age of 50, but this data is significant. And the other is mothers and children are disproportionately affected, with greater than 55% in those groups. So when it comes to vision impairment and blindness data from Ethiopia, I'm a bit unhappy to share with you. I'm referring to all the data because that is the only national data that we have, which was conducted back in 2005, 2006. And we are referring this data because we don't have any other national level data. We have been using this for programming, resource mobilization, and advocacy as well. So with that national survey, the blindness prevalence rate is 1.6%, and low vision prevalence rate of 3.7%. This is significantly high, particularly compared to sub-Saharan African countries. This is a very high prevalence rate. And if you translate this to the number of people affected by blindness or low vision, that can relate to millions and millions of people. There have been some RAB surveys. RAB refers to Rapid Assessment of Avoidable Blindness, which was conducted recently in Amhara, in Oromia, South and Central Ethiopia. This provided some data. It's conducted in the age group of people above 50, and it provided some data like between 3 to 4% of people above the age of 50 have blindness prevalence. And we are waiting for the second national survey at Ministry of Health. We are working as a group. We have developed the protocol, the sampling, and what have you, including the budget. And we are ready to engage into the second national survey, which will provide us a most recent update. Definitely, there will be change because we have been doing a lot over the last 2 decades. So we are looking forward to it, and we're going to share you if the survey finding will be released in the coming years as well. With all national survey, what are the causes of vision impairment? When I say vision impairment, it's blindness and vision impairment as well. Number 1 is cataract. Half the cause of vision impairment is cataract. And the other is trachomatous trichiasis. It's very unfortunate that I'm referring here, trachoma. It is one of the oldest infectious disease affecting mankind. It has been a major public health concern in Europe, in Americas, and in Asia. They have significantly reduced, and it's no more public health issue in those countries. But in Africa, and particularly in Ethiopia, it's still a major public health concern. In fact, Ethiopia has greater than 20% of the global TT, and without any investment in Ethiopia, the set target for trachoma elimination is 2030, and it will be a futile exercise. So we need donors, government leaders, influential political people to understand this and give attention for the elimination effort that we are undertaking. Refractive error is still a major cause of vision impairment. As indicated in the global data, glaucoma is also a major cause of vision impairment in the country as well. Here is a very powerful slide indicating the burden of trachoma. I have indicated it's a major public health concern. As you can see, close to 70 million people in Ethiopia are at risk of acquiring this infection. So it's very unfortunate. And in terms of the blinding form of the disease, which is called trachomatous trichiasis, greater than 20% are in Ethiopia. This section of my presentation I'll stop here, and I'll hand over to my colleague, Dr. Yihalem, for the economic aspect of our presentation. Dr. Yihalem, I'll hand over to you. Berhan, in the meantime, if there are any questions requiring clarification, I will be more than happy to respond to.
Thank you, Dr. Ylemayehu. I think we can have the reflections, clarity questions at the end of the presentations. So we can have Dr. Yihalem to continue his presentation. Thank you. Dr. Yihalem,
Dr. Yihalem?
You can start your presentation.
Okay, sorry. Can you make me a host? Or
I think you can continue with the presentation shared by Dr. Ylemayehu.
yeah, I can use my mobile, but for PC it is not working. Am I audible?
Yes, we can.
Okay, thank you so much for the opportunity and Dr. Ylemayehu for your excellent brief on health.
Yihalem?
Yeah.
Apologies, there is a double sound from your audio. Maybe if you could mute something that's behind.
Yeah, let me fix. What about now?
It's good now. Can hear you.
Okay, thank you. Okay, thank you, Dr. Ylemayehu, for your nice presentation on the health burden of blindness and vision impairment. I will continue on the economic burden of such blindness and vision impairment, which is very important for policy making, resource allocation as well. So the issue of blindness and visual impairment is an invisible threat to the global economy, which is not just anticipated or expected as like the health burden. About 411 billion US dollar is being lost as a result of such vision loss every year. But this significant money can be invested for building schools, hospitals, roads, and many other infrastructure. So it has significant implication or loss of the global economy. When we see the share for blindness and vision impairment, nearly 44 billion US dollar is lost due to blindness, and around 367 billion US dollar just lost due to moderate and severe vision impairment. In 2018, the Lancet Commission on Global Health report showed that about 0.3% of the combined GDP of the global economy is lost as a result of blindness and vision impairment, which is significant. And around half of all the global productivity losses from the same report is shown as concentrated in South Asia and the high-income North America. When we come to the case of Africa, particularly to the Eastern Sub-Saharan Africa, around 0.3% of the Eastern Africa GDP is lost due to these two problems, vision impairment and blindness. Next slide, please. For the case of Ethiopia, just you can expect, but there is no such established data for our country. That report didn't include the issue of Ethiopian context, and also there are no economic costs of blindness and visual impairment related studies in Ethiopia, but we can expect that the blindness and visual impairment would be more significant, higher. So it is very critical concerning the issue of economic burden of blindness and visual impairment in the Ethiopian context, where we are contributing a major share to the trachoma, where the first in such prevalence globally and other cause of blindness. So due to such context, Ethiopia also is losing significant productivity loss from the GDP. When we see the details of such economic costs of blindness and visual impairment, the vision loss, it leads to around 30% drop in employment, the existing employment for those affected with blindness and vision impairment. Related to education, the children with vision impairment, most of the time they achieve less educationally, and at later age, they have an impact on future earning and productivity. So it has significant effect or impact on the education sector as well, in addition to the employment. Next, vision loss has also deep economic impacts, including job loss and reduced work efficiency. And vision loss also increases healthcare expenses as a result of accidents and long-term care emanated from such blindness and visual impairment. Accidents will be a possible issue related to such blind people. So there will be also long-term care associated with such blindness. So that will increase the healthcare expenses. So this is a significant report. The other one is vision loss not only affects the individual entity, their livelihoods, but it also affects their family and also the nation as well. Just it has a broader societal economic burdens. These statistics highlight that there is a need for investment in eye health. We can prevent these losses by investing on eye health, which is very important investment. We will see next about the benefit of investing in eye health. Next slide. Next slide. Okay, thank you. So when we see we have seen previously about the losses as a result of blindness and vision impairment. So what return or economic benefit will gain as a result of investing in eye health? The first one is the value of early detection and treatment, where just preventing the occurrence of blindness and such vision impairment would result in saving in further healthcare costs as a result of later detection and treatment of cases. So it is very important that in educating the citizens, the cost of education is or prevention is just lower than the cost of treatment or further healthcare delivery after the occurrence of such blindness and vision impairment. The second one is related to boosting productivity, where as we know, productivity loss as a result of such blindness, vision impairment is high. So restoring their vision can empower individuals themselves, and also it leads to increased workplace efficiency, and finally they contribute to the economic growth overall at country level. Third, regarding to return on investment compared to other area of investment in health, the Lancet report also reported that investing $1 investment on, for example, refractive error or cataract correction leads to $36 return in benefits, which is very important. So the issue of investing in health is very important. When we see the current investments at global level, even though there is a wide disparity about the investment in eye health from country to country, some countries, they allocate between 1.5% to 0.7% of health expenditure to eye health, which is good, but it is not as expected to have such a resource allocation. And regarding to the cost effectiveness of such eye health intervention, the return on investment, both in terms of the health outcomes that already mentioned before, and the economic benefits from such eye health is very important, and most of the time it surpasses many other health interventions. Next slide. Yeah, this figure just summarizes what the return on investment is. So eye care intervention return compared to interventions in other areas of the health sector shows that $1 investment on eye health leads to a $36 return for eye health, whereas it is $13 for nutrition intervention, $9 for non-communicable disease, and for all development, it is $6. So this highlights that investment on eye health is very critical for a country to have such return on investment. Next slide. Thank you.
Hi, Berhan, can I continue?
Dr. Ylemayehu, yes, you can continue, please.
Thank you. Thank you. So we have attended the burden of blindness and low vision or a visual impairment, and we have seen the economic implication and the burden. And I would like to share you what is going on right now in terms of eye health system in the country. I have categorized into three groups. Number one, the eye health workforce or human resource for eye health. The World Health Organization has a recommendation for the different eye health cadres per population. So one ophthalmologist is almost serving 500,000 or 500,000 population in Ethiopia. We have 240 ophthalmologists. This data may be a little bit updated recently, but I have used the information from the Ministry of Health. So with that number, currently, Ethiopia has one ophthalmologist serving almost 500 million, while the WHO recommendation is that one ophthalmologist should serve 250,000 population. Here, I have included both general ophthalmologists and specialists as well. And the second is, the second is the optometry. Right now, we have 760 optometrists in the country operating in the government and the private sector, which relates to serving 160,000 per optometrist, while WHO or the International Agency for the Prevention of Blindness recommends one optometrist per 1,000 population. The other is the allied eye health professionals. These are different eye health professionals with different level of training and also different service provision ability. So one allied eye health professional in Ethiopia right now is serving 275,000 population, whereas WHO and IAPB are recommending one allied eye health professional should serve 100,000 population. When I say allied health professionals, I have included here ophthalmic officer, ophthalmic nurses, and also cataract surgeons. The other is one primary eye health worker for 100,000. This is the most recent data I have. We have 1,200 integrated eye care workers. These are general nurses or health officers trained on primary eye care, particularly focusing on TT surgery, and provided all the supplies and the support to do screening, referral, and TT surgery at primary level. Whereas the World Health Organization and IAPB recommend one primary health worker per 5,000 population. I think here you can see the disparity, the need, the gap in terms of the health workforce. I think as a nation and as per recommendation to WHO, we need to collaborate and enhance maximizing quality workforce to ensure we have at least one arm of the service provision. And the other is infrastructure. We have close to 921 primary eye care units across the different regions in Ethiopia. These are mainly integrated eye care workers providing, as I have said, primary eye care and also TT surgery, but also provide screening for cataract, refractive error, referring to the second level. In some primary eye care units, we are now seeing optometrists taking up that role, which is a very important move going forward. We have 57 secondary eye care units. These units are staffed with ophthalmologist or a cataract surgeon. At least they are providing regular and outreach cataract surgical services. On top, they may have optical workshop producing affordable or low-cost eyeglasses to the needy community, primarily focusing on schools and also presbyopic correction. The other is the tertiary units. These are teaching or academic institutes. One in Tigray, the other in Gondar and in Bahar Dar, the other in Addis Ababa, like Minilik, St. Paul, and Alert. Probably Alert may not be tertiary, but the two are the key one. In Hawassa, in Jimma, these are the tertiary eye care facility. When I say tertiary, they are providing training to different eye health cadres, number one. They are providing different subspecialty eye care services. And on top of that, they are doing some level of research. So as you can see, we have primary, secondary, and tertiary level facilities. In as much as possible, we have to link these units in terms of ensuring patients receive the best eye care services. One thing that I didn't include here is the community level service, mainly targeting health extension workers. They are focusing on the preventive aspect of diseases, mainly focusing on trachoma, but also engaged in some level of screening and referral. So these are the infrastructure and as a nation we have. In terms of policies and guidelines, as you all know, the World Health Organization have many strategic documents that could be adopted or tailored depending on the context of the nation. So Ethiopia used the WHO guidelines in many areas in developing national level strategy, in ensuring cataract and other services, in developing monitoring and evaluation, in relating eye care to the 6 building blocks, what have you. So we rely on the WHO guidelines for starting to develop our own national level guidelines or policies. We have also, as a nation, our own national health policies. Until recently, eye care may not have the right place in those policies, but it's getting much attention now. So we are seeing eye care is included in most of the national level health policies. And the other is specific to eye care. We have a 3-year eye care strategic plan developed by the National Committee for the Prevention of Blindness, endorsed by the Ministry of Health. I think this is our guide in terms of ensuring eye care is within the healthcare system and providing accessible, affordable eye care service to the needy community. And in terms of trachoma, we have number one, the WHO endorsed the road to elimination of NTDs by 2030, which we have adopted in a way and developed our own master plan or strategic plan for NTDs. These are neglected tropical disease strategic plan. So trachoma is clearly indicated there. So by 2026, according to the strategic plan, 75% of endemic districts should control or eliminate trachoma, which in a way by 2030 should eliminate all the remaining districts, endemic districts. So combining all this in the context of healthcare system, where are we? Is it adequate? No, it's not. That's why I said earlier that we need collaboration, enhanced partnership, and also engage policy makers to put eye care in the right development agenda. The other very important initiative which comes recently from WHO is that integrated people-centered eye health service. I think it is reframing this approach. Yes, we used to be patient-centered, but this one give it more attention, because in whatever way we deliver eye care service, I think patients have the right to make informed decision to determine their health outcome as well. So it is a continuum of health intervention covering eye health promotion, prevention, treatment, and rehabilitation to address the full spectrum of eye conditions according to their needs, coordinated across the different levels that I have described at community, primary, secondary, and tertiary level, and beyond the health sector. I mean, we don't have to focus only on the healthcare system. What about the education sector? What about the finance sector? What about the agriculture sector? So we have to think beyond the healthcare system to ensure patients have the right service that they deserve, and recognize people are participants and beneficiary of these services throughout their life course. I think to ensure to achieve IPEC, there are 4 strategies, that is empowering and engaging peoples and communities across any initiative, starting from planning, implementation, monitoring, and reorienting the model of care, and coordinating service within and across sector that I have described earlier, and also creating an enabling environment in whatever way. I mean, within the healthcare system, in the finance, and the other aspects as well. Thank you. I'll hand over to Dr. Yihalem.
Okay, thank you. Just I will highlight you about the consideration of universal eye health coverage within the overall universal health coverage agenda by the year 2030. In the figure, there are 2 cubes, the green one and the rest one. So there are dimensions within the cube. So this, on the left side, the length shows the current eye health service provision, what Dr. Ylemayehu has already presented, what it looks like in terms of the workforce, in terms of the service, exact service, and the policies, and so on. So what the service looks like. So from where to where we would like to go. And this focus on access to essential eye health service provision in the Ethiopian context. So this indicator is showing the proportion of the population covered by eye health services. So the aim is to increase population coverage for essential eye health service provision, which is very important for the government and other partners to collaborate with for increasing population coverage of the eye health services. The second on the right side is the width shows the service coverage, whether it is with quality or not. So this shows the proportion of all available essential eye health services, which eye health services are available and which are remaining. So there are different causes of blindness, vision impairment. So all services, all essential services should be availed to citizens. So the aim is to deliver more services, extra services beyond the existing service, but it should be with quality. The height shows the health spending by the government in collaboration with other stakeholders, funders, and others by contribution from the community-based health insurance and others in the Ethiopian context. So this shows the proportion of direct eye health service costs covered from the pooled fund. So how much the government is spending from the treasury, then collecting also from the insurance, the case of community-based health insurance, from donors. So the main purpose is to reduce out-of-pocket expenditure for those patients visiting health facilities at the time of service uptake. So the aim is to reduce financial hardship during service delivery, and also protecting them from further impoverishment as a result of such medical expenditure. So this Q shows the overall context of what the health service looks like in the Ethiopian context in relation to access, how much of the population is accessing important eye health services, the issue of access, and are the available services even with quality or not, and also is the government having appropriate or optimal allocation of the related resource in terms of health spending, particular to eye health. So this universal health also contributes to the overall universal health coverage agenda that is aimed by the year 2030. So this is very critical. The Lancet Commission has reported the essentiality of the universal eye health coverage, which has important implication on the health, the economy, social, and other aspects of specific country or at global level. So this is very important that the governments and other partners should work more on this to increase access and improve quality, and also protecting the beneficiaries or patients from financial hardship and further impoverishment. Next slide.
Sorry, Dr. Yihalem, before we proceed to the final way forward, can we have questions from the participants, and I'll give you an opportunity to summarize your presentations, including the way forward. Would that be possible? Okay, thank you. Thank you, Dr. Ylemayehu and Dr. Yihalem. That was a wonderful presentation and it was insightful. So now can we have questions from the participants? There are also questions on the chat box. Maybe Dr. Ylemayehu and Dr. Yihalem can prepare your response for the questions, but at the meantime, let's take questions from audience. So I see you can raise your hands, and I see Abebe Mirchao, if you could hear me. Abebe Mirchao.
Okay. Thank you. Is it audible?
Yes, we can hear you, Abebe.
Okay, thank you, the presenters. That was a very nice presentation, but my question is that you are telling us this trachoma is the major problem of Ethiopia. I don't think so, that nowadays there is some shift in trachoma prevalence, but you are putting the figures which was posted in 2006, which is far from the current prevalence. And can you tell us the current trachoma prevalence of the country? And also, nowadays, most of our people are suffering from non-communicable disease induced eye problems like diabetic retinopathy and the like. So what will be the role or your role to alleviate this condition? Thank you.
Thank you, Abebe. I see hand from Abufeta. Abufeta, can you hear me? You can continue with your questions.
Yeah, thank you for your giving this opportunity. I want to ask you some questions related to, for example, we have, as WHO guidelines shows us under the data that are the shareholders represent as most likely it shows us with this data is less in our country because of we didn't have too much ophthalmologists based on our Ministry of Health capacity, based on, for example, for those who will be trained are less. And in case of the far area, for example, the far area of the central is the patient does not get the well management, for example, for some diseases, and that they didn't get any follow-up regarding to that issue. So my question is how we can eliminate for such kind, and even though how we can connect it to the society, to the area that they can get proper investigation and management, for example, awareness. That's my question. Thank you very much.
Thank you, Abdul Fattah. I think the other hand I see is from Masarat Kasa. Apologies if I pronounce your name wrongly. I just read from my screen. I have missed the titles. So can we continue, Masarat Kasa?
Okay, thank you, Berhan. Thank you, Dr. Ylemayehu, Dr.Yihalem, for the enlightening presentation. It was very much informative. I just have two questions. The first one is, you have put a nice summary box here, the two cubes. I appreciate that. But can you, Dr. Yihalem, can you put some figures? For example, when we say proportion of populations covered, you have put it in dimensions, but really how much are we, in terms of this publication or this document, how much proportion of, or how much percentage of the population are we effectively reaching in eye care? Do we have those figures if they are available? Because Dr. Ylemayehu was stating we are probably halfway in human resources, specifically for ophthalmologist coverage, the number of ophthalmologists to population ratio. So with the current rate of 35 up to 40 ophthalmologists produced every year, so by 2030 or 2031 or 2032 maximum, we might be able to reach to the WHO target. But with the current distribution of ophthalmologists, do you think our level of care or our professional coverage will meet the standard? Because the numbers are not very bad. As of now, we are halfway, but the level of care is not halfway, obviously, because as we know, most people are concentrated in the capital and major cities across the country. So what is your recommendation? Is there any policy recommendation in this regard? The second question is on funding or resource allocation. As we all know, partners contribute a lot in Ethiopian eye care. And with or without that, how much are we spending and how much does it fare with international recommendations or our neighboring countries? So do you think we are making the necessary funding even as compared to our GDP or per capita? How do you see that the amount of resource we are actually putting? How much percentage of the healthcare budget are we directing towards eye care? If you have those figures, because these are policy advices. So where should we act actually? What should we change from what we have been doing in the last several years to make a meaningful progress and to achieve the 2030 goal? Thank you very much.
Thank you, Masarat. Any more questions from the audience? Okay, maybe for this round, can we respond to the questions already raised, and we'll come for the second round maybe, if the time allows us. So I think I will give an opportunity for Dr. Ylemayehu to respond to the questions which are directed to the burden of blindness. So Dr. Ylemayehu, you can continue.
Thank you. Thank you very much, Berhan, and thank you also for the audience for asking those questions. In terms of trachoma, I presented the most recent data, which refer to the May 2024 data. For your information, the Global Trachoma Mapping Project, probably you might have heard about it. That is the first large-scale, robust mapping conducted in the NTD space. So every endemic district in Ethiopia is mapped. So there is data at district level, not at national level. I mean, that's where the implementation is there. That's where the programming is there. So we have the most recent data I'm referring to. So it's called the Tropical Data System. We have a standardized protocol where a team will go in a district and do a baseline or impact assessment. So there are two cadres there, the grader, who are trained, certified, according to the criteria set, and they are the one going house to house, documenting the presence or the absence of TF in children 1 to 9 years of age. So what I can tell you is that Ethiopia as a nation have the most recent data, not at a national level, at district level. So we are referring to that data. So this is a map taken from the International Trachoma Initiative, which is a highly expert group of trachoma experts evaluating every district, submitting a request for the mass drug administration aspect. So one thing I can tell you is that we have the most recent data, not the 2006 data. The 2006 data refers to regional and national prevalence rate. That's a very crude prevalence rate, and it may not be useful for implementation at district level. But the most recent one have that aspect. That's one thing. So based on the Global Trachoma Mapping Project, which was conducted in 2013 and 14 in Gregorian calendar, I think let's talk about the TT part, the trachomatous trichias, which is a blinding form. Ethiopia used to have like close to 800,000 TT backlog back then. And since then, we have been doing a lot of TT surgeries. There are some data referring to more than 1 million has been conducted. But the problem is, no matter how TT surgery you performed, unless the incidence rate is controlled, there will be, incident cases coming up, filling that pool. That is a major concern. The most recent data we have is we have like 300,000 TT backlog. And the problem here is, if you do TT surgery, even in the best hand, the recurrence rate is close to 10, 15%, 1.5. So that means as we go along, a recurrent TT will be a major public health concern. And when I say close to 300,000, that includes both incident and also recurrent cases. That is the issue. So in terms of the healthcare system, I think we train integrated eye care workers. We train ophthalmologists on providing quality TT surgery training in terms of PTT management and so on. So this is where we are in terms of trachoma. I'm not sure whether I addressed the question or not, but the data I'm referring to is the most recent data. That's one point. In terms of diabetic retinopathy, I think what can we do? I think number one, recognize that it's a major public health concern. Now, I mean, go to any rural community, there may be a chance that you can get diabetic patients there. So I think number one, we need evidence, data. With the second national survey that we are looking for, we have included the DR aspect in the study. So if funding is not an issue, that will provide a most reliable and recent data. But in the meantime, I think public awareness, health education to our community is a critical part. So they have to know that there is a problem called diabetic, and they have to get checked for general diabetic or diabetic retinopathy. I think that's one thing. The other thing is we have to be also equipped in the healthcare system, be it in the human resource aspect, be it in the diagnosis and management aspect. This requires a much higher strategic engagement within the ministry, within the development partners, the academic community, and you as a professional. I think every one of us has the responsibility to make sure that those cases should get the right screening and the right treatment. But this requires, as I have said, strategic engagement. And I think the Ophthalmological Society of Ethiopia is a key partner in the national survey proposal, and we have also a responsibility to take that seriously. I think that the third question goes to Dr. Yihalem, but in terms of one question from my friend, I think I would like to refer to the old Vision 2020 strategy. It has 3 strategic pillars. Number 1, disease-targeted program. Number 2, infrastructure. And number 3, human resource development. I think the 3 has to go hand in hand. If we have a major disease problem like cataract, for example, do we have the infrastructure? Do we have the unit, the secondary eye care unit doing the surgery, or the tertiary eye care unit doing the surgery? Or do we have the primary eye care unit doing the right screening and referral, and also the right human resource? Do we have cataract surgeons, ophthalmologists, optometrists doing the different aspects of cataract management? So as a nation, we need to have very strict and very firm, ensuring equitable distribution of human resource and also other resources as well. I think, as Dr. Masarat rightly said, a significant proportion of ophthalmologists are located in major towns and cities. Based on data 15 years ago, close to 75% of the ophthalmologists were located in major cities and towns, whereas 84% of the Ethiopian population is living in rural settings. So you can see a clear disproportion of the distribution. So this requires policy influence, strategic direction, and collaboration as well. If you do that, I think that's very important. I think regional health bureau have now the semi-autonomy to recruit, to assign ophthalmologists to where the need is. So working with the regional health bureau is also a very important initiative. In terms of funding, Dr. Masarat has raised, I think the question goes to Dr. Yihalem. But just to give you some clue there, the problem with eye health, it's not considered a killer disease. So in a country where we have major public health issues, killer diseases, the resource, the attention goes to that side, leaving aside eye care to the development partners. So Orbis, Light for the World, the Carter Center, Fredol's Foundation, CBM, these are the major eye care stakeholders providing probably the human resource, the infrastructure aspect of the service. I think we have seen a much improved engagement at federal level on trachoma issue, which is a very good, very encouraging development. I think we have to capitalize, we have to build on those opportunities. Recently, the Ministry of Health allocated close to 30 million Ethiopian birr for the national survey. That tells us that the Ministry of Health is being engaged in this initiative. And going forward, I think all of us, professionals, associations, the national committee have to provide the right information to make informed decision at Ministry of Health level. Thank you. I will hand over to Dr. Yihalem for the other question.
Okay, thank you, Dr. Ylemayehu. I will reflect on the live questions and also from the chat box. Thank you all for your questions, which are very relevant. So let me just reflect on the issue of funding and resource allocation in the context of eye health service in the Ethiopian context. So the burden of such blindness, visual impairment is not well known in Ethiopia, as I have presented it before. Let me tell you that overall in the Ethiopian health system, in relation to the Abuja declaration, about 15% of the GDP should go to the health sector, it says. But in the Ethiopian context, it is overall 6%. The Ethiopian health sector is getting 6% from the overall GDP, which is almost more than half lagging from that 15% standard. For the case of eye health, it is not just difficult to estimate how much we are just allocating for that. There is no evidence how much is being allocated to eye health in general. If we are investing 6%, the government from different sources pulling that money is spending 6% from the GDP for eye health. You can estimate how much the eye health is being funded. So there is no evidence in Ethiopian context as far as the literature is concerned. So that is my response. About the cube here, these are important indicators. They are not similar to the usual indicators we use for monitoring and evaluation. It is based on index. WHO just recommends to use index for access, index for service coverage, and index for financial risk protection, and also to the level of impoverishment protection. So it is based on index. For example, we are not focusing on a single cause of blindness like cataract or trachoma and the like. There are different disease entities, eye health problems that causes just a problem. And the services are also targeted to those causes. So at the very beginning, there should be a minimum package of eye care service in Ethiopia that should be available. So from that minimum of package of eye care service, how much is the population is covered, whether it is in the rural, urban, in the pastoralist, whatever context. So this increased population coverage is a bigger picture that focuses to access and equity. So it is not a single indicator that will refer to a single disease entity. For example, if there are 7 causes of blindness, for those causes, there are respective services. So we can just estimate the coverage, the population coverage, how much is the population covered with that services. That the green one shows the current eye health service provision for respective problems. So there is no specific figure that is tailored to the Ethiopian context. It is the global society or community relation to eye health that puts this figure as understanding universal eye health coverage in the context of overall healthcare. So there is no figure about such population coverage, financial risk protection, and service delivery coverage in relation to eye health. I can definitely answer. From the chat box, I can just answer one raised the issue of access to rural community. Yeah, just the unreached segment of the population or such far from the health facilities, those facilities are available in around the towns or cities and also some rural parts. So there are communities not getting such service, for example, women and children and others. So there is no full coverage of such eye health service, as already Dr. Ylemayehu mentioned. So we are not referring that there is 100% coverage or such evidence. So still we are not covering the wider segment of the population based on need. In relation to the economic burden association or change with severity of the visual impairment from mild to the level of blindness, yeah, we can just expect that the healthcare cost increases when the level of severity increases. That long-term care, in the case of hospital and any other form of care, and also a palliative care to the level of their lifespan, which will increase. So there are direct medical costs, direct non-medical costs, indirect costs, and so on. So it has a direct association that economic burden will intensify or increase when the severity also increases. One last, the economic burden of such blindness, visual impairment compared to other health conditions. Yeah, just we can just entertain that such global economy around 411 billion US dollars is being lost by such major cause of blindness, visual impairment. So we can just refer that the issue of blindness, vision impairment would outweigh the burden compared to other single cause of a disease like malaria, TB, HIV, or any specific cancer. These are my points I would like to reflect. Back to you, Berhan. Thank you.
Thank you, Dr. Yihalem. Thank you, Dr. Ylemayehu. That was brief and to the point to the questions. I hope everyone has gotten a clarity on the questions. Maybe one question I have is there any cost-effective intervention for preventing blindness in Ethiopia so far? Maybe if you could if I can give some answers for that, maybe we can also. I think our time is about to end, so I think the questions in the chat box are all addressed. Maybe Dr. Yihalem, if there is any response to that, or Dr. Ylemayehu, we can respond to that, and we'll proceed with the post-test questions.
Okay. Yeah. As far as the literature is concerned, there is no well-established cost-effectiveness study in Ethiopia in relation to blindness and vision impairment. There may be for trachoma, there is in the pipeline to test the issue of electrolysis, whether it is effective or not, to TT case. But there may be pocket or such studies. But at global level, the Lancet Commission has reported that there is a gap in cost effectiveness studies at global level due to methodological limitation on such cost effectiveness study. And second, it is related to expertise in such health economics or economics overall, and related to funding. This is what I have. Thank you.
Dr. Yihalem. I think the post-tests are posted. We'll take a few minutes for the post-test. And then maybe, Dr. Yihalem, there are questions on the chat box. Maybe there are about 5 questions which are not reflected on. Dr. Yihalem and Dr. Ylemayehu, maybe if you could note that and include them in your summary. We'll have 5 minutes for summarizing your presentations. So maybe if we could include them.
So hi, Berhan, can we go to the last section, or are we waiting the questions?
Post-test is posted. So
Okay.
I think let's have a few minutes to
Okay.
have those completed, and we'll proceed with the presentation.
Okay. So sorry, I'm not seeing it in the screen, Berhan. Is it coming? Oh.
Yeah, it's a link that's dropped in the.
Oh, okay. Okay, good.
Thank you. I think we can proceed to the summarization and concluding the presentation. Dr. Yihalem and Dr. Ylemayehu, we have 5 minutes So we can continue with the summary.
Yeah, can you share the slides again?
Okay. Yes.
Okay, thank you so much. Before that, I will just respond one question from among five questions posted later in the chat box. Do you mean that the Ethiopian health system should be donor dependent still? It says it is not actually. Just we are advocating further. We are just bringing an evidence that first preparing essential package of eye care services is very important, like the exempted health service, like the insurance for the maternal and child health service and so on, so that the eye care service can get attention from the government to be funded. So domestic resource should be used in a sustainable manner. Just the donors will support, they should continue their support, but we are just in the long run aiming to further invest from the domestic resource. This is what I have. So regarding to the way forward, I will just summarize in the next 4 or 5 minutes. So as we have just presented, visual impairment and blindness and their economic burden in Ethiopia is huge. We can just emphasize that. So let us give attention for this issues of burden in Ethiopian context. So the need for quality eye care service expansion is obvious, we know, and it needs policy influence and optimal resource allocation in such provision of quality eye care service in the Ethiopian context compared to the population need for eye care service, which is very important. Since there is no well-established evidence related to economic burden of blindness and impairment in our country, in the next, we just recommend a modeling exercise regarding to the economic cost of blindness and impairment in our country. So that will be used for policy making, important decision making in resource allocation, so that eye care services could be provided to the population that need it. The other one is we propose the integration of vision economics. Just until now, most of the evidence is just circulating around the epidemiological profile of such blindness impairment, the causes, the prevalence, and its health consequence. So vision economics should be also integrated within the existing surveys, like the proposed second national survey. So that is very important. And we also just recommend to have resource need analysis, what the eye care services are needing to implement the such service in the Ethiopian health system, what are the available resources, and also what is the gap in resource by comparing the needed resource and the available resource that will be mobilized, which is very important for next resource mobilization and resource allocation. And finally, we just recommend there should be a health policy analysis of the existing national policies, strategies, roadmaps, and so on, about their content, whether eye care service is getting attention more. So that based on that finding, we can further influence the policymakers and decision makers to have optimal resource allocation, give due emphasis to eye care service, which has an economic burden that should be averted so that the return will be high. These are the way forward we would like to pass. Thank you so much for your attention. Thank you.
Thank you. Thank you, Dr. Yihalem. Thank you, Dr. Ylemayehu. That was insightful presentation, and I would also like to thank the participants, Ima, for organizing this seminar topic. It was insightful. I hope we have all gained the required knowledge. With this, I would like to say thank you all, and I think according to Ima's guideline, the certificate will be issued for those scored above 15. So you will also get more information from IMA coordinators. So thank you everyone for the presentation.
Thank you so much. Okay.
Thank you, Berhan, for your
Bye.
moderation, nice moderation, and the audience. Thank you so much, Imam and Ophthalmological Society of Ethiopia for such opportunity. Thank you so much.